Assalamualaikum. My name is Hunza Irshad and my roll number is BP1650086 and my group is 39. Today I am going to present a case study about renal failure. Kidney failure, also known as end-stage kidney disease, is a medical condition in which the kidneys are functioning at less than 15% of normal levels. Kidney failure is classified as either acute kidney failure, which develops rapidly and may resolve, and chronic kidney failure, which develops slowly and can often be irreversible. Symptoms include leg swelling, lethargic feeling, vomiting, loss of appetite, and confusion. Complications of acute and chronic renal failure include uremia, high blood potassium, and volume overload. So here is a case study. Kathy is 47 years old, female, on hemodialysis. Her end-stage renal failure is presumed to be secondary to diabetic neuropathy. She is a known case of type 2 diabetes mellitus, which was diagnosed in the year 2008. She has a right brachiocephalic fistula as her vascular access for hemodialysis. She had some excess issues related to high venous pressure and prolonged bleeding after removal of the fistula needles. In addition to this, she has a past history of coronary artery disease and had coronary angiogram done, which showed 80% of stenosis of the left anterior descending artery with minor circumflex disease. A metal stent was inserted in the left anterior descending artery on the same year. Her chief complaint was hypertension and shortness of breath. Her SOAP notes included subjective findings, which includes shortness of breath secondary to fluid overload, bilateral pitting edema in both legs, hypertension, diabetic ulcer was noted in the left foot. And the objective findings were 47 years old female on hemodialysis, diabetic neuropathy, renal failure secondary to diabetic neuropathy, missed 3 sessions of hemodialysis, past history of coronary artery disease, coronary angiogram done in past, blood pressure of 198 by 110 millimeter of mercury, respiratory rate was 28 per minute, and saturation 98% with 4 liters of oxygen. Hyperkalemic with potassium of 6.8 millimolar per liter, urea 40.1 millimolar per liter, bicarbonate of 19.0 with elevated C-reactive protein level. Assessment: she was seen by the renal team and was advised for urgent hemodialysis and was transferred to dialysis unit as per the missed dialysis protocol for the hospital. She was given 2 hours of heparin-free treatment with 1.5 liter of fluid removal. She was then transferred to renal ward for further care. She was referred to diabetic foot clinic for further review for her foot ulcer. She received 5 daily doses of intravenous tazocin as advised by the infectious disease team. She had her missed dialysis protocol completed over 3 days, which resolved her shortness of breath and bilateral foot edema. She was reviewed by the high-risk foot team for the ulcer, and dressing was done as per the instruction, which reduced the slow clean edges and controlled the pain and wound healing with no evidence of surrounding cellulitis. So the plan was urgent hemodialysis urgent hemodialysis to be continued for 3 times a week, treatment of hyperkalemia using calcium resonium, improve level of comfort through the maintenance of ideal target body weight without excess fluid, advise patient to take only 500 milliliter to 1000 milliliter fluid each day, aspirin 100 mg to improve the patient of arteriovenous fistula and to prevent any thrombus formation, injection piperacillin and tazobactam 4.5 grams twice a day to treat foot ulcer, glycylazide 20 mg daily with meal to prevent hyperglycemia, and calcium carbonate tablet 1250 mg 3 times per day with meal to prevent absorption of phosphate absorption, metoprolol 50 mg per oral due to history of coronary artery disease, clopidogrel 75 mg oral per day due to history of coronary artery disease, and metal stent, vitamin tablets, as the dialysis process eliminates large quantities of water soluble vitamins such as vitamin C, B complex vitamins, and folic acid. So, Kathy is a chronic renal failure patient along with other comorbid conditions, so she should care as much as she can and avoid missing of further hemodialysis. Her family must take care of her and contact her consultants whenever there is an elevation in her symptoms associated with her condition.